Hey guys, so good afternoon. It's another Monday. You guys are two-thirds done with this class and all doing a really great job. So today we're going to be talking about medical emergencies or sudden illness, some of the major types of illnesses that could be imminently life-threatening to an individual, such as respiratory emergencies, cardiac emergencies, seizures, stroke, diabetic emergencies, and so on. Just going to have a little bit of an introduction to the emergency itself, talk a little bit about the physiology and the pathophysiology of what these emergencies involve, how to recognize the immediate signs and symptoms of emergency, and of course, what to do as a first aid provider for the first few minutes until professional resources can get on the scene. So the first thing we'll talk about is respiratory emergencies. Emergencies that result in sudden onset of difficulty breathing. There are a number of conditions that can lead to an onset of respiratory distress in an individual or a feeling of they can't breathe. Too many to name in this class right now, but it's kind of interesting that in the field of EMS, the call type difficulty breathing is one of the most common call types that come in the 911 system. And when you think about it, one of the reasons for that is not only can you have problems with the respiratory system itself, but the respiratory system can also be affected by problems with other organ systems as well, such as the cardiovascular system, the nervous system, the endocrine system. So any problem in the respiratory system can really manifest itself in many different ways. So just to go over a little recap of the anatomy and the physiology of the respiratory system, remember that the chief components of the respiratory system are the lungs and the accessory structures. And the purpose of the respiratory system is to get oxygen into the body to be distributed into the cardiovascular system so all the cells can live, and to help with the elimination of carbon dioxide and waste materials. And so we do that by bringing the lungs into the thoracic cavity. I think we covered this a couple of weeks ago, which is a closed chamber. And so when you want to bring air into the lungs, you have two major muscle groups, the diaphragm and the intercostal muscles. And what they do is they contract and they expand the container that's called the thoracic cavity and decrease the pressure within inside. And as that happens, the lungs, which are hollow structures in themselves, are pulled open passively by the expansion of the chest cavity. And when they're pulled open, they draw air, mostly oxygen, from what we're concerned about, from the atmosphere into the lungs via the airway, the nose, the mouth, the pharynx, the trachea, the bronchi, and the bronchioles. And then when we are finished taking enough air, the lungs send a message to the brain, which tells them that they're full enough, and the brain sends a message to say, stop inhaling. And then the natural recoil, or the natural stretchiness of the chest wall just snaps back like a string and pushes the air back out, causing an imbalance, a constant imbalance of air in and out of the lungs. Anything that can disrupt that process can cause a problem in the breathing mechanism, leading to a respiratory emergency. Any blockage of air, such as a foreign body airway obstruction, blockage of air because of constriction of the bronchial tubes, any problems with the alveoli themselves, if they're becoming damaged or they're not allowing oxygen to diffuse into the bloodstream, any problems that impairs the ability of the chest to expand and contract, like an injury, certain neurologic diseases like polio, any problems that allow blood to actually get to the lungs and pick up oxygen, such as a blood clot. Anything at all can really manifest itself as a problem with the breathing mechanism. But one of the most common causes of a sudden onset of difficulty breathing is a very common medical emergency called asthma. Now, many people have heard of asthma. Some people don't really understand what asthma is. Some people have a condition of asthma. Some people have had it all their lives. It's a condition in which the lung passages, the bronchioles, those are the muscular tubes that carry oxygen from the upper airway all the way into the lower areas, the alveoli, become irritated and they go into spasm and they swell and they start secreting a lot of mucus and other inflammatory conditions, which obstructs the ability of those bronchioles to transport air and oxygen to and from the lungs. Now, what actually causes asthma, we are still not 100% sure of. There's probably a big genetic component to it. We know that people that have severe seasonal allergies are more prone to asthma attacks. But we do know that there are certain things out there that can trigger or can set off an asthma attack, some of which being environmental pollen, mold, pet dander, dust mites, which just about everybody has in their pillows and bedding. Probably one of the biggest triggers for asthma attacks are the droppings of cockroaches, which usually found in more unmaintained and unkept crowded buildings. But it's still a pretty significant public health situation. You have places like Harlem and the South Bronx, which are really the asthma capitals of the world. And it's estimated that about 1 out of every 4 children will miss a significant amount of school time due to problems with poorly controlled asthma. So, what are the signs of a sudden, severe asthma attack? Well, for the first one, obviously shortness of breath, maybe not feeling like you can get enough air in, but with asthma, it's usually a problem getting the air out. It can be a persistent, non-productive cough. Most people correlate the term wheezing with asthma. What do we mean by wheezing? Well, if you saw this slide a couple of slides back of the bronchial passages, what happens during asthma? So here you have one side, you have a nice open bronchial passage where air is getting in and out nice and easily. But during an asthma attack, what happens? The bronchial passage swells, it constricts, and it gives a lot less room for that air to go through, cause some resistance and what we call turbulent airflow. Now, when we take a breath in and we expand everything in our chest cavity, that pulls the bronchial passages open, making air transport through it a little more easy, facilitates it. But what happens when you exhale? When you exhale, everything contracts and constricts. And so what happens when you have a bronchiole that's already tight and narrow, constricting even further, you're having a much more difficult time getting that air through that bronchial passage. So asthma is usually considered what's called an obstructive respiratory disease. So usually a person having an asthma attack will initially have some difficulty, not necessarily getting the air in, but getting the air out. They'll usually feel a little tightness in their chest, a little resistance to exhalation. Now, if the attack gets further and further, they can have it on both ways. They can have problems getting the air in and getting the air out. Just important to understand that not all people with asthma wheeze. And that's actually the cause of the wheezing, too, is that constricted bronchiole, which causes a whistling type effect. Sometimes a person with just a persistent cough that won't go away with a history of asthma could be experiencing an acute attack, in which case sometimes they need a little bit of help. Well, what kind of help are we talking about? Well, obviously we're not trained to give definitive medical care, but a lot of people who have a pre-established diagnosis of asthma will carry an albuterol pump or an asthma pump, a rescue inhaler. We call it a rescue inhaler. It's to help stop these attacks while they're occurring. And what most of these inhalers do is they have medicine in it that helps stimulate the sympathetic nervous system, which helps allow the bronchial passages to open and stop spasming, and will make it a little bit easier for that person with the asthma attack to start breathing. What's the role of the first aid provider in assisting somebody having an asthma attack? But really, it's just a matter of helping to facilitate getting that albuterol pump to them. Some people may not know where it is. They may be too tired. They may be too much distressed to get it out of their locker or their drawer, bedroom. So it's really just a matter of getting it to them and help coaching them through the process. There should be a video on your lesson plan to show the proper use of an inhaler. Basically, what it does is primes the respiratory passages to open up. But it has to be prepared first. The cap has to be taken off, has to be shaken up. The person's got to be able to kind of coordinate pumping and breathing in at the same time. And that's the best way to do that. Sometimes they may be a little hesitant to do that. If it's a moderate to severe attack, they may be a little too jittery or a little too anxious to be able to coordinate that on their own, in which case it's kind of the job of the first aid provider to kind of coach them through, monitor them, and of course, obviously keep an eye on them. If the medicine's not helping, if they're still breathing hard and fast, if they have what's called nasal flaring, nostrils flaring, opening up, they cannot walk or talk well. One of the biggest signs of a severe asthma attack is if a person cannot complete sentences. So instead of speaking in a complete, full structured sentence, they have to stop and take a breath in between each word. That is not a good sign. If they're breathing too, they're turning blue in the face, that means they need a little more intervention than we're able to give as first aid providers, in which case have a low threshold for calling 911 or getting them to the emergency department as soon as possible. If it's a mild asthma attack that's just not responding to their rescue inhaler therapy, some local urgent care centers may be able to assist, but if they're really severe distress, get them to the emergency room, because asthma does kill, especially in children. I think if you remember way back in the beginning of the course, we talked about the biggest killer of adults being heart disease, the biggest killer of children, aside from accidents, being respiratory diseases, and asthma is way up there. If a child, or anybody for that matter, goes into cardiac arrest due to an asthma attack, they are not coming back. So get them the professional help sooner than later. Another interesting phenomena you might see out there is something called hyperventilation syndrome. Usually, 9 times out of 10, and don't quote me on the statistics, it's due to some type of panic or anxiety attack. The person feels like they can't catch their breath, they start breathing rapidly, then at some point they feel like they can't control their breathing. You couple that on top of the inciting incident that started the panic attack, and it's just kind of a whirlwind of events that can become very problematic. It's not life-threatening by any means, but what you're seeing in this picture is the common layperson treatment for hyperventilation syndrome, which is absolutely wrong. A lot of times you'll see on TV or you'll see other people in day-to-day life saying, oh, put a paper bag over their face and have them breathe into it because they're breathing out too much carbon dioxide. In theory, that is correct. Most people who are having what's called hyperventilation syndrome will start losing control of their breathing. They'll start complaining of pins and needles in their fingers, their toes, numbness around their mouth, and that is because they're breathing out too much carbon dioxide. The problem with giving a paper bag over their face and having them rebreathe their own carbon dioxide is that in the field of first aid, you never know 100% why their rapid breathing is because of an anxiety attack, which is a diagnosis of exclusion, or if it's something else going on, such as a partially collapsed lung, a blood clot in the lung, a severe asthma attack. So putting a paper bag over their face and cutting off their supply of oxygen is really the last thing we want to consider doing at that point. Recognizing hyperventilation, well, they're going to feel short of breath, they're going to be breathing rapidly. The tingling around the hands and the feet and the numbness around the mouth is usually because blowing off too much carbon dioxide too fast changes the pH and the chemistry of the bloodstream. Not to such a great deal, but to the degree where it can start causing little muscle twitches and spasm in these areas. And of course, dizziness and lightheadedness is also a consideration as well. So what's the proper care for a hyperventilation syndrome? Best bet is really to try to just calm and reassure this person. By having them try to talk it out, gives them control over their breathing. Now, there are many different types of meditative breathing exercises out there. Um, you may want to try to have them do one of these if you can, if you feel comfortable with it. One particularly effective one is to have them breathe in through their nose for a count of 4 seconds, holding the breath for a count of 5 seconds, and then breathing out slowly through pursed lips like they're trying to blow out a single birthday candle for a count of 8 seconds, and having that do them 4 times in a row. By the way, this is not on a test. This is just a little suggestion that I've picked up over years of experience. But again, if there's any shadow of a doubt that this person is experiencing hyperventilation due to other causes, then don't have any hesitation to call 911. Don't feel like you have to be stuck managing the situation all alone. Another common respiratory ailment is chronic obstructive pulmonary disease, and COPD for short. And it's kind of interesting that, well, we'll see what happens with the statistics after this COVID situation throughout the year, but up until recently, it's taken over the #2 spot of the most common cause of premature deaths of adults in the United States. Now, it's a broad term that could be applied to different medical conditions: emphysema, chronic bronchitis, things like occupational lung disease, like you're seeing in a lot of your 9/11 responders. Most common factor for chronic obstructive pulmonary disease is cigarette smoking. It usually occurs in the older person. Not all people with COPD um, smoke cigarettes. There are very few, less than 1%, who actually have a genetic predisposition to it, but by and far, cigarette smoking is the #1 cause of chronic obstructive pulmonary disease. And you have two major types of COPD. One is called chronic bronchitis, and chronic bronchitis is defined as a chronic cough for at least 3 months out of the year for at least 2 years in a row. And the pathophysiology of chronic bronchitis is the fact through those years of cigarette smoking and toxic inhalation has destroyed the lining of the bronchial walls. If you remember back from anatomy, there's certain tissues that make up certain structures. The inner lining of your bronchial tissue is filled with epithelial tissue. And out of that epithelial tissue, you have all these microscopic hairs called cilia, which work to sweep out dust and debris and little dirt particles, microscopic particles, sweeps it up out of the bronchial tree into the mouth, where you either expectorate it by spitting it out. Most of the time, you swallow it with your own saliva, destroy it in the GI system, and most people don't have a problem with that. The problem with your COPD is through years of usually smoking, they've destroyed that ciliary lining. So dust and debris gets kind of caught up in those bronchial passages, which stimulates more and more mucus production, more and more inflammation, which allows them to or kind of facilitates them to cough excessively to try to get rid of all that dust and debris out of their respiratory systems. Sometimes they're not very efficient at doing that, so a good COPD attack can also lead to eventual severe community-acquired pneumonia, in which they are really sick. The other type of COPD is something called emphysema. Emphysema is another situation that usually occurs through years of cigarette smoking, where you have destruction of the alveoli in the bronchial tree. Now, you remember the alveoli is where air exchange or oxygen is exchanged into the blood, carbon dioxide is exchanged from the blood into the airway for elimination. So over the years, those alveoli become distorted, they become stretched out, flimsy, and basically useless. So as more and more of those alveoli become useless, you have less and less surface area for oxygen and carbon dioxide exchange throughout your lifetime, leading to a constant state of shortness of breath, a constant state of trying to get air, get carbon dioxide out of the system. And usually what happens, which leads this to an emergency, is some type of normal respiratory virus, cold virus, uh, allergy attack, anything like that, which pretty much just kicks these diseases into gear and causes them to become what we call acute. So remember, chronic obstructive pulmonary disease is something that a person has their whole life, or for the remainder of their life. When you have a flare-up of COPD, that's where the emergency is. And what's the intervention for a flare-up of COPD? Sometimes these patients are prescribed rescue inhalers, just like your asthmatics, in which case you know how to assist them with that. And other times it's just a matter of recognizing the distress that this person is going through and getting them to the hospital, calling 911 as quickly as possible. So the next emergency we would like to talk about is heart attacks. Heart disease is still the #1 cause of death of adults in the United States, to this day at least. And there's a lot of reasons for that, a lot of risk factors that come into play with heart disease. Cigarettes, #1 preventable cause of preventable risk factor for heart disease. Obesity, especially people who carry a lot of body fat in the stomach area. Sedentary lifestyle. The body was pretty much made for work. It was made not to sit around and play on the internet all day. Poor diet that's high in saturated fat profile, diet that's high in what we call very simple carbohydrates, not complex carbohydrates like fruits and vegetables, simple carbs like starches and sweets. Family history is very significant. There was a baseball player years ago called Darryl Kyle for the St. Louis Cardinals, found dead in his hotel room, and on autopsy, they found that he had almost all the major arteries to his heart blocked up, and he died of a sudden heart attack in his sleep. Most people think, oh, 31-year-old athlete probably overdosed on something. That was not the case. He did have a significant family history of heart disease that he basically probably played a role into what happened with him. And of course, as we age, as we get older, things tend to get a little bit less efficient in their working. That can be a risk factor for heart disease as well. So how does a heart attack actually occur? What is the process that occurs? Well, through the process of all those risk factors that we talked about, it occurs when blood flow to the heart is either reduced or cut off. Now, I might have mentioned that the heart itself is a hollow organ. It has 4 major chambers, 2 atria, 2 ventricles, and blood is constantly flowing through these chambers. But the blood that flows through the chambers does not feed the tissue of the heart itself. The heart muscle, called the myocardium. Myo, the prefix pertains to muscle, cardium, C-A-R-D, refers to heart. The heart muscle gets its oxygenated blood supply by blood vessels that wrap around the outside of the heart, called coronary arteries. The coronary arteries are the first arteries to get their fill of nice new oxygenated blood from the left ventricle as they branch directly off the aorta. They're also the first arteries to get the full of all the crap that we put in our bodies over our day-to-day activities. So if you ever heard the term coronary artery disease, that is the precursor to what we call a heart attack. Now, there are a couple of situations that can lead to a heart attack. If you look at the diagram here, you can see what we're talking about. So first is the term atherosclerosis. Atherosclerosis is the buildup of fatty plaques on the inside of the artery that makes it more resistant to blood flow. Now, a person can go around with up to about 70% of a coronary artery blocked up from these fatty deposits and still have no problem doing their day-to-day activities. What happens though is as these fatty deposits build up on the inside of the inside of the artery becomes weak, especially that wall, right outside that endothelial lining. And at some point, the inner lining of that artery can become weak, damaged, and rupture. And once that rupture, part of the blood that seeks out irregularities and damage to the blood vessel, the platelets, start accumulating. They want to try to patch up the damage. That's what the body's supposed to do under normal circumstances. Problem is, sometimes the body's a little too good at what it does. So if too many platelets try to patch up that defect, they're going to wind up blocking up that whole artery. And that whole artery is blocked up by this platelet plaque, we call it. Everything downstream from that artery is not going to get any oxygen. And so that person is going to go through what's called a heart attack. That heart muscle is going to become ischemic. See that word right here? Ischemia refers to lack of oxygen to the tissue. And this person will start experiencing a heart attack, or in medicine, what we call a myocardial infarction. The prefix myo refers to heart, cardia, muscle. Infarction means death of. So without any blood supply to that area of the heart, that piece of heart muscle will die. It's not a one-shot deal, it's a progression. It's something that occurs over several hours. And if it's picked up on and treated early enough, the process could be reversed. An individual could make a complete recovery. We'll talk about that later. So just again, we mentioned this in CPR, but we'll mention it again. Heart attack is different than a cardiac arrest. Many people mix up the terms. Heart attack, one or more of the blood vessels delivering blood to the heart muscle becomes blocked off, and the heart muscle starts becoming damaged. Now, a heart attack can lead to cardiac arrest, but it's not cardiac arrest in itself. What is a cardiac arrest? The heart stops beating effectively. Either stops beating completely, or it goes through a few minutes of this spasming, quivering type mechanism we call ventricular fibrillation that you learned in CPR, basically leaving it ineffective as a pump. So, and that's what we're trying to prevent by recognizing the signs and symptoms of a heart attack. So what are the signs and symptoms? Remember, what's the difference between a sign and a symptom? Sign is something you could see, hear, feel, smell, not necessarily taste, whereas a symptom is something that the patient has to subjectively tell you what's going on. And the most common sign, or I should say symptom, of a heart attack or myocardial infarction is chest discomfort. Now, it can be very subjective. Some people say I have crushing pain in my chest. Some people just say I have a little pressure. Some people say I just have an uncomfortable sensation. Some people describe it as a burning sensation. 5 people could be in front of me in the hospital. They could all be having myocardial infarctions and describe their pain 5 different ways. So it's you can't really just rule it out based on their description. Now, discomfort in other areas of the body. A person having a myocardial infarction may either also or only complain of pain elsewhere, such as the left shoulder or the jaw or behind between their 2 shoulder blades. That's something we call referred pain. And the reason why that happens is because the sensory nerves from one structure, the shoulder, and the sensory nerves from the other structure, the heart, travel up and they crisscross right before the spinal cord. And once in a while, a signal can get mixed. So the brain actually perceives what's going on in the heart as something going on in the shoulder. That's called referred pain. So that's something, again, when you have somebody who's elderly, who has risk factors for heart disease, all of a sudden starts complaining of pain in their shoulder and left arm for no reason, with no injury, should have a high index of suspicion that this may be cardiac related. and may want to convince them to seek medical care. Other signs could be breaking out into a cold sweat for no reason. I had a patient in the ER one time, lady in her mid-80s who otherwise looked extremely healthy, came into the emergency room because she thought she was coming down with the flu, because in the middle of the night she broke out into a cold sweat. That was her words. No pain, no shortness of breath, but because of her age, because of protocol, we needed to work her up a little bit. We did an EKG, which had some abnormalities, so we did some blood work, and bam, they found out that she was actually indeed having a heart attack in process, and that was her only complaint. So got to put all the factors together. Nausea and lightheadedness can also be somewhat common. What's not mentioned here in this slide, which something that should be taken very seriously, is what we call an impending feeling of doom. I know that sounds dramatic, but if you have somebody who, as you know, has some risk factors for heart disease, they're older, they smoke, or whatever else, and they look sick, and they're telling you, oh God, I think I'm going to die. I think I'm going to die. Take that seriously. I've had a nickel for every time I had a patient looking like that, telling me they think I'm going to die, and the next minute I'm firing up the defibrillator. I'd have a few nickels in my bank account. Trust me on that. So what would you do for this person? Well, listen, really, there's many different causes for chest pain. Some life-threatening, some benign. Problem is, it's hard enough to rule out the differences even in the emergency room. It's impossible to do it as a first aid provider. So unless really they just pulled a muscle lifting a bench press, when in doubt, call 911. And it's much better to call 911 than to transport the patient to the hospital yourself. Not every hospital is adequately or optimally equipped to deal with a heart attack. Some heart attacks are more serious than others. Some hospitals are specialty referrals in dealing with heart attacks. The EMS system knows which hospitals these are. Most other lay people don't. Cab drivers and Uber drivers don't. Sometimes it's in the patient's best interest to go to a hospital that's a little further away than the nearest community hospital to get the proper treatment. Many times people want to go to the hospitals that their physicians are affiliated with. That may not always be the best case. So call 911 regardless. Watch their breathing. Have them open up any loose, restrictive clothing and keep them in a comfortable position. Try to minimize activity. Don't let them walk it off. Don't let them go back to their chores, their activities. The more activity, the more oxygen demand. The more oxygen demand to the heart, with the less ability to deliver that oxygen, is going to cause more damage to that heart muscle. Caveat here. If the patient has no what we call contraindications, it's a very good idea, if you have aspirin lying around, I mean not lying around on the floor, but obviously the right place, especially baby aspirin, to have them take an aspirin. Baby aspirin actually tends to work a little bit better. What aspirin does, it prevents one platelet from calling out to another, and it helps slow down and reduce the incidence of blood clotting. Contrary to what you've heard your whole lives, aspirin is not a blood thinner. It does not decrease the thickness of the blood. It does not decrease the viscosity of the blood. It helps prevent further platelet aggregation. So hopefully we prevent this artery from going from 95% blocked to 100% blocked. It's a very effective, very life-saving, and very important medication. It's 99 cents for a bottle of 100. You really can't beat that. Why does baby aspirin work better? Because by chewing it up, it tends to get absorbed through the glands under the tongue, which we call sublingual, and goes right into the bloodstream. Whereas swallowing an aspirin, taking a glass of water and swallowing it into the digestive system, well, first it's got to get broken down by the digestive system, then it's got to get metabolized by the liver, and there's going to be a delayed reaction to the aspirin working where it's supposed to work. But either way, whatever you have available, aspirin is a very, very good intervention as long as the person does not have any known allergies to aspirin. Now, what are allergies? Allergies are something that causes the body to react unfavorably, either through hives, sweating, difficulty breathing, rash. Uh, if you ever assist somebody with a medication, the first thing you always want to ask is, do you have any allergies? They say, yeah, it just hurts my stomach. That's not really an allergy to an aspirin. It's not really a reason not to give aspirin. If they've been treated for a bleeding ulcer recently, do not give aspirin. That can facilitate that bleeding even further. You can talk about nitroglycerin. I'm definitely not going to hold that on an exam. Nitroglycerin is a medication that's been prescribed to cardiac patients for over 200 years. Yes, it's also been used as an explosive and dynamite for railroad workers, but I know you're not going to make the patient explode. But what does nitroglycerin do? It actually helps open up the remaining coronary arteries to facilitate more blood flow to the heart to help maybe compensate for that blood flow that's been compromised in that one artery, one or more arteries. It's very rarely prescribed anymore because of new cardiac interventions, making it not really necessary. But every now and then, you may have someone who's been prescribed this by their doctor and has been told by that doctor to take this if you start developing any chest pain. A couple of things you have to watch out for, and most importantly, and all jokes aside, if the person has taken any type of erectile function enhancers such as Viagra, Cialis in the last 72 hours, do not assist them with their nitroglycerin. I repeat, do not assist them with the nitroglycerin. The combination of these two types of medications can cause a dramatic drop in their blood pressure that can lead to either stroke or death. So that's something that Viagra was originally developed as a blood pressure medication, blood pressure agent. It was originally developed to help lower blood pressure. And then in the clinical trials, when some of these subjects were trying it out, they noticed this happy little side effect. I was like, whoa, what's going on here? And the pharmaceutical company said, well, look at this. Well, there's so many other blood pressure medications on the market. Probably not going to make a big profit selling this as a blood pressure medication, but as an erectile enhancement medication, this is a gold mine. Just a little bit of trivia for your own information. That, again, will not be on the test. Bottom line is, if they do take nitroglycerin, and if you're going to assist them with a nitroglycerin, make sure it's their own nitroglycerin, not somebody else's, to avoid any other complications. Sometimes people have chronic chest pains or repeated episodes of chest pains from stress, exertion. This is something we call angina pectoris. Usually, this chest pain is relieved once they rest, once they take a nitroglycerin, but sometimes it's very difficult to appreciate what's a temporary angina episode versus more serious myocardial infarction. People who have narrowed blood vessels to their heart at rest may be completely fine, but when they increase the oxygen demand to their heart, like you see in this picture, what's going on here? Well, you got a gentleman who's a little up there in years, carrying some, looks like a heavy load, walking upstairs, walking through the cold winter storm, a whole bunch of factors into play to cause that heart to really start working into overdrive and to start causing him chest pains. You get him out of all those factors, you reduce the workload of the heart, chest pain tends to go away. So that's something we call angina. And academically, we can go through the whole criteria of the difference between angina and myocardial infarction. Just bottom line is angina tends to go away with rest or nitroglycerin. Myocardial infarction does not. But when in doubt, always assume the worst and assume that a myocardial infarction is occurring and call 911. Okay? And a general rule of thumb is if this person has a history of angina, they're resting, they're taking a nitroglycerin, if they have it, and the pain's not going away in 5 minutes, call 911. If the pain does go away and they look like they're doing okay, you don't necessarily need to take them to the emergency room, but you would definitely want to encourage them to follow up with their doctor, maybe their cardiologist, and just see if anything has changed in their cardiac status. Fainting. Fainting occurs when there is a transient, meaning temporary, loss of consciousness or near loss of consciousness, leading to the loss of a person's ability to maintain themselves upright and winding up collapsing. And most often, fainting occurs when there is a reduced or temporary reduction in blood supply to the brain. Remember, the brain is the most sensitive organ for oxygen deprivation. And so any temporary loss of oxygen to the brain will cause a momentary shutdown, which will also shut down the rest of the body functions and cause a person to collapse. Probably one of the most common causes of fainting is stagnant blood flow. Somebody who's been sitting in a squatting position, like a plumber or a mechanic or something to that effect, whose blood has pooled down to the lower extremities and gets up too fast, may experience a delayed blood flow to the brain. May start feeling lightheaded and collapse. There are certain people who are on different types of blood pressure medications that slow down the blood flow in the body, and if they get up out of bed too fast, they may not have enough blood supply to the brain to keep up with that. There are some situations which causes the blood vessels in the body to all of a sudden open up quickly, reducing peripheral vascular resistance, reducing blood pressure, reducing perfusion, and they may wind up collapsing real quickly, like when they go through something called psychogenic shock, seeing they got a 60 on the exam instead of the 90 that they thought they were going to get. Many different causes for fainting. Anxiety, dehydration. If a person's been running marathons and not been replacing their fluids, at some point, their blood's going to get a little thicker. It's going to have a harder time getting to the brain. Low blood pressure. Now, the question is, what's causing that low blood pressure? Now, a very common thing to occur in your elderly population is something called a vasovagal. And that's a term you won't need to know on your test, but it's an unfortunate situation. As we get older in life, in the 60s, 70s, a lot of these people tend to have difficulty passing bowel movements. And when they're in the bathroom and struggling to have a bowel movement, it's not coming out, what's the first thing we tend to do? We tend to break down, bear down, and try to hold our breath to push it out. That process of doing that can actually stimulate a nerve in the body called the vagus nerve, which stimulates the heart to actually slow down. That's something called a vagal response. Sometimes it actually leads to an elderly person's demise. So quite often, if you go into the 911 field and you respond to a cardiac arrest, you may actually see your patient on the floor in the bathroom, wedged between the toilet and the bathtub. What happened was they bared down, they had a vagal response, which led to fainting, and unfortunately, due to other medical circumstances, they never recovered from it. So that's a sad situation. Any type of irregularity of the heart can cause fainting as well. Sometimes the heart can go into overdrive, and instead of beating at a normal pace of 60 to 100 beats a minute, like most normal adults, it can go into 150, 200, 250. A lot of different types of conditions that can cause this. Atrial fibrillation is one, supraventricular tachycardia is another, ventricular tachycardia is another. But if the heart's beating too fast, it doesn't allow enough blood to fill the chambers. And if enough blood doesn't get in, enough blood's not going to get out. If enough blood's not going to get out, enough blood's not going to get to the brain, hence causing lack of perfusion and fainting. Same thing if the heart's beating too slow. I mean, there are some very, very well-conditioned athletes that have a resting heart rate in the low 40s, sometimes even high 30s. But these are extremely, extremely conditioned people whose hearts have been trained to squeeze every little bit of blood out with each contraction. The norm is not to have a heart rate that low. So what do? I mean, the first aid for fainting or possible fainting or imminent fainting is pretty easy. Help prevent the person from falling. Don't get yourself in any trouble. Don't you get yourself hurt. If a 300-pound, 6'5" individual is collapsing, don't try to catch him in midair. You might wind up getting hurt yourself. But if you can ease them down to the floor, that's usually the best thing to do. Loosen any tight clothing at the neck and waist to enhance breathing. Stay with them until they recover. If the loss of consciousness is complete, then of course what you want to do is turn them over onto the recovery position, monitor them, monitor their breathing, and call 911. And if it's a real hard fall, however, best bet is to, and they've lost consciousness, best bet is to keep them in the flat up position, maintain the cervical spine, look for head injuries, and treat accordingly. Where it says help the victim regain an upright posture, take that with a grain of salt. If you think that they are really sick, if they're pale in the face, if they have that ashen look of death on their face, or if they've sustained any type of injury, if they banged their head on the floor or neck on the edge of a table or something like that, be hesitant to help them up into the upright position until EMS gets there. A cold, wet cloth on the face may help a little bit. Don't do what some people do in the TV shows and splash them with cold water. That's never an effective treatment for fainting and can only lead to them breathing in water and having an aspiration pneumonia. And of course, one episode of fainting, if they're just dizzy, if they're lightheaded because they're a little dehydrated, and they normally have a very good state of health, doesn't necessarily have to go to the emergency room unless it occurs over and over and over again. This is a person whose heart may be going into funky rhythms. If they do not gain responsiveness, if they lose responsiveness again, or you really can't figure out why they fainted, then it's best bet to get them checked out. Again, always better to be safe than sorry. Okay, so let's talk a little bit about diabetes and some of its causes, but its effects. Stan, this is a very, very underappreciated, not well understood in the general public disease that leads to a lot of different complications. It's the second leading cause of blindness, toe amputation, major risk factor for heart attacks, and just to name a few problems. And what is diabetes actually? Well, it's a condition of poor glucose control in the blood. Now, how does that happen? Well, when you get hungry, what do? You eat something, whatever it is, candy bar, power bar, sandwich. That food gets into your digestive system and it gets broken down by the stomach and the small intestine and ultimately gets released into the bloodstream. As it gets released into the bloodstream, your blood sugar level, your glucose level, goes up. Goes up to the point where it releases hormones that tells you to not feel hungry anymore. But you don't want that blood glucose level going too high. So if it goes too high, that can cause a cascade of other problems. So when the pancreas, which is an organ in the abdominal cavity, senses that the blood sugar level is too high, it releases the hormone insulin. Insulin allows glucose to enter the cells of, well, just about every cell, but mostly of the liver and skeletal muscles as storage, so it has some place to go. Then once the blood sugar level normalizes, over several hours, the blood sugar level is going to drop a little bit. And once the blood sugar drops a little bit, you are going to feel hungry. And how are you going to respond to that hunger? You're going to want to eat. And so you eat, the whole process starts over again. So in a normal healthy individual, that blood sugar level is kept in a relatively common, relatively stable zone. Person with diabetes lacks that ability to keep that blood sugar level under control. They either do not make enough insulin or they have problems using the insulin that they have. The end result is usually the same. Too much blood sugar piling up in the vascular system and no sugar being used for cellular metabolism. So if glucose cannot get into a cell, the cell cannot properly make energy to do what it needs to do as a cell. Now, the cell can use other things for energy besides glucose. It can use fats. The problem with using fats for energy is that it leads to a lot of toxic byproducts, things like ketones and acids that can ultimately hurt the body, hurt the nervous system, hurt the muscular system. So we don't like to really burn too many lipids or fats as an energy source. Your body can also break down proteins for energy. The problem with breaking down proteins for energy is that you got to take them away from something else. You got to take proteins away from muscle tissue, hormones, nerve tissue, anything that proteins are used for structure and functions, enzymes. So that's not really the best bet either. So we'd like to be able to burn glucose as fuel. It's a nice, efficient fuel source, and its byproducts are very easily eliminated. Byproducts being carbon dioxide and water vapor. So you may have heard the term type 1, type 2 diabetes. Type 1 diabetes, it's not really called type 1 diabetes anymore. It's more commonly referred to as insulin-dependent diabetes. It used to be commonly referred to as childhood diabetes or child onset diabetes. And usually occurs in this situation is that usually very early in life, pre-adolescent or teen years, child starts becoming very sick. They become very ill, they become nauseous, they're losing weight, they're losing energy. So mom will typically take this kid to the doctor. If they're really bad, to the hospital. They'll do a simple little blood test and they'll find that their blood glucose level has skyrocketed. In which case, that child goes under some additional tests and they find that the pancreas is failing. And what causes that? We're not 100% sure. There seems to be a combination of genetics and maybe some viral exposures that occurred while the child was still in utero developing. We're not 100% sure. It's definitely a genetic component to it. And so with that situation, this child or pre-adolescent or whoever it is going to require what's called exogenous insulin or external insulin for the rest of their life because their body's just not making insulin. Now, if they were to go without insulin for any period of time, the body would just basically break itself down and they would pee out to the point where they'd be dehydrated, go into shock and die. So that's really not an optimal situation. It's not a situation that can be ignored. There are many different types of insulin on the market. There's some short-acting, long-acting. That process is very diverse and complex. Type 2 diabetes, which is commonly but not always referred to as adult onset diabetes, occurs as we get older. It has been called non-insulin dependent diabetes, but even type 2 diabetes, when it's poorly controlled, will ultimately lead to needing insulin. It's a natural progression of the disease, unless it's very, very strictly monitored. But type 2 diabetes usually occurs around 30s, 40s, 50s, when the pancreas seems to be putting out insulin. However, the cells can't really use them for whatever reason. Think of it as a football team where you have a quarterback that's taking the snap, getting the passes off, beating the line, beating the rush, throwing good, precise passes, yet the receiver just can't catch the ball for whatever reason. So that's kind of what's happening at the cellular level. The insulin's getting there, but the cell is not taking it. So the end effects are still kind of the same. The cell is going to break down other materials like fats and proteins for energy metabolism. And then you're going to have all that excess glucose storing up in the bloodstream. When you have all that excess glucose piling up in the bloodstream, the blood gets thicker. Blood flow in the aorta and the major blood vessels may not be such an issue, but in the really, really tiny blood vessels of the eyes, the kidneys, really micro organelles of the body will show significant damage over time. So type 2 diabetes is initially managed with different types of oral medications. Some medications that stimulate insulin production in the pancreas, some medications that slow down the release of stored glucose from the liver, and a combination of few of them. You may have heard the term gestational diabetes. Gestational diabetes is the onset of diabetic attributes while a woman is pregnant. It's thought to have to do with the release of hormones and estrogens, really escalating the amount of sugar that's released into the bloodstream and the inhibition of insulin production. And there is somewhat of a myth of gestational diabetes that once a woman has given birth, the diabetes disappears. It does not. They may not show traits of diabetes for years after delivering, but any woman who has been diagnosed with gestational diabetes is really someone who is probably prone to developing type 2 diabetes, and the gestational diabetes has accelerated the process, kind of just identified it. So if that woman is not really careful with her diet and her health throughout the next few years, she will wind up becoming type 2 diabetic in the long run. Okay. So what are your two major complications of diabetes? So it's very simple. Either your blood sugar gets too high or it gets too low. Blood sugar that's too high is called excessive glycemia. GLY, the glycogen, refers to blood sugar. Or you can have too low, which is hypoglycemia. Hypo. Well, what happens with hypoglycemia? Because this really is the true immediate life-threatening emergency. Well, as I said, if you're a diabetic who is counting on insulin to maintain glucose balanced metabolism in your body, as we said before, when your blood sugar crashes a little bit, you get hungry, you eat. You eat, the food gets broken down, glucose gets released into the bloodstream, it normalizes, and then it maybe elevates a little bit. The pancreas senses that the glucose is elevated. It's signaled to release more insulin. More insulin will take the blood glucose, and whatever is not being used already will get stored into the liver, the skeletal muscles. If the glucose level drops to a certain degree, now you start feeling the sensation of hunger, you eat, the whole cycle starts all over again. When a diabetic is given insulin on the outside, what we call that process, by the way, is a negative feedback process. Just kind of like the same way a thermostat works. Okay, you set your thermostat in your house to 70 degrees. The ambient temperature stays about 70 degrees, all is good. The ambient temperature drops below 70 degrees or to a certain preset temperature, like 68 degrees. Your heating system senses it, and it kicks on, turns the boiler, and the boiler starts producing more heat. Once the ambient temperature reaches a certain level, back to 70 degrees, that heating mechanism shuts off and stays monitored. Well, when we're putting insulin in from the outside, we've kind of lost that negative feedback mechanism. We've kind of lost that control. So type 1 diabetes is treated by giving shots of insulin, different types of insulin, deposited either into the muscle or to the subcutaneous layer of the skin. And that insulin is just slowly released consistently throughout the day. It could be short acting that works very quickly, or it could be long acting that works over the next 24 to 36 hours. But either way, that insulin does not respond to peaks and lows in the blood glucose. So once it's given, it's given. So now, if you wind up giving too much insulin, well, that could be a problem, because that can wind up having all the glucose stored into the liver and the muscles before it gets to the brain. And obviously, the brain needs two things to function at all times. It needs oxygen and glucose. If an insulin-dependent diabetic has taken their insulin and forgotten or was skipped a meal for whatever reason, well, what's going on? They have the insulin still being released into their bloodstream, but no glucose for it to act upon. So whatever little glucose is in there is immediately going to get stored into the liver, skeletal muscles. And that insulin that's floating around in the bloodstream is not going to allow what stored glucose is in the liver to get released into the bloodstream. That's going to keep the blood sugar level very low. Severe exercise will burn up a lot of excess calories and sugar. So athletes who have diabetes, they have to be very, very vigilant about monitoring their blood sugar and adjusting their insulin dosages to compensate for the activities that they're going to do during the day. Alcoholism is a big problem, because alcohol inhibits the liver. It's toxic to the liver, and it may inhibit the liver from releasing glucose, stored glucose in the form of glycogen, when it's needed as the blood glucose level drops. So these are the problems with hypoglycemia. Hypoglycemia is an immediate life-threatening problem. Okay, its onset occurs very quickly, and it can kill the person. Hyperglycemia is a serious situation as well, but that usually takes days to weeks for it to occur. So if you're recognizing about low blood sugar, that is the immediate problem here. It's a sudden onset. It's characterized by things such as staggering, poor coordination, clumsiness, anger, agitation, pale color, shaking, trembling. Now, think about all these signs and symptoms we just talked about. What can that commonly be confused with? It could be confused with alcohol intoxication or drug intoxication. So, something you have to consider when you have somebody acting a little bizarre. If it gets too far into the process, the patient can wind up going into seizures, unconsciousness, and then ultimately death. And that's obviously what we want to avoid. So we want to recognize the signs and symptoms quickly. And again, hunger, sweating. Usually sweating is a very, very telltale sign that the blood sugar has dropped, because the blood sugar drops. Remember, any immediate life-threatening condition kicks in the fight or flight system, the sympathetic nervous system. And one of the things that happens is the skin becomes cool, pale, sweaty, and diaphoretic, cold and clammy, as opposed to high blood sugar, hyperglycemia, which is a very gradual onset, will cause weakness, drowsiness, extreme thirst. Usually a person's going to wind up urinating quite a lot, because that's one way that the body tries to rid itself of all that excess blood glucose. It's filtering out through the kidneys and trying to get rid of it, although that's only a little bit of a temporary effect. Vomiting, because perfusion to the GI system is not working very well. It says fruity breath odor and heavy breathing. Fruity breath odor is not really the best adjective. It's more of an acetone, nail polish remover type smell that you get on the patient's breath, again, which can sometimes be confused with alcohol. And the reason that happens is, remember, the glucose is in the bloodstream, but it's not getting into the cells. So the cells cannot use glucose for energy production. So what do the cells do instead? Break down fats. The normal breakdown of glucose for energy yields a lot of energy, 36 ATPs, and the byproducts are carbon dioxide and water, which are easily eliminated. They go through the bloodstream and they're eliminated out the breath. When the body metabolizes fats, lipids, for metabolism, you don't get as much of an energy payout, about 2 to 4 ATPs. You don't have to remember that. But the big problem is the byproducts. The byproducts of fat metabolism are substances of acids and ketones, keto acids. And those can be very toxic to the body. They affect the nervous system, the musculoskeletal system, the endocrine system. So the body tries to get rid of those keto acids as quickly as possible. And one of the ways those keto acids are released is through the breath. Those chemicals combine in the red blood cells, they're taken up to the lungs, and they're released with the normal carbon dioxide and other mechanisms. Now, so giving that person's breath a very pungent odor. So that's one of the telltale signs. The skin is usually going to be dry rather than diaphoretic because this person's going to be dehydrated. And again, the take-home point here is even though they're both emergencies, hypoglycemia is going to occur very quickly. Hyperglycemia occurs over days. It's a long process. A diabetic with hypoglycemia, one of those reasons that we talked about, could be acting completely normal and rational at one point, and then maybe 30 minutes later, start showing signs of agitation, confusion, restlessness, sweatiness, in which case it's important for the first aid provider to respond, react. First thing to do is obviously make sure they're not behaving in a way that puts you in any danger, and then start talking to that person. Do they have diabetes to begin with? One of the first things to check for after you've done your ABCs is, do they have a medical alert tag? It's something that tells you that they're diabetic if they're not able to tell you themselves. Well, what is the telltale treatment for hypoglycemia? It's giving sugar. Giving something sweet and sugary to either eat or drink. The immediate problem is to get that blood sugar back up so those brain cells are not dying. Now you may think to yourself, oh, diabetes. They always said diabetes shouldn't be eating sugar. They shouldn't be eating carbohydrates. They should be cutting that. Yeah, this is an emergency situation. Emergency. Normal blood sugar level is usually in the range of about 80 to 120 milligrams per deciliter, and that's just for reference. When a person becomes symptomatic from hypoglycemia, their blood sugar has probably crashed to a point where it's about 20 to 40 and dropping. If it gets any lower than that, the person's brain is going to shut down and it's going to die. So if they're awake and if they're able to physically follow commands, your best bet is to get them a glass of orange juice, a candy bar, soda, nothing diet. Non-natural sweeteners like aspartame and saccharin will not do anything to elevate their blood sugar level. It's got to be something with sugar in it. And then call 911. Now, if the situation occurs where this person is unresponsive and unable to swallow on their own, do not, this is a bad thing that you've seen over the years, do not put anything in their mouth while they're unresponsive. No wedges of orange slices. Do not try to pinch their nose and pour some juice down their mouth. It'll only wind up going into their lungs and killing them. In which case, you just need to call 911 and let them know that they're unconscious and immediate 911 response is needed. So another condition to talk about is stroke. And I'm sure we all heard the term stroke before. What is a stroke in the broad sense? A stroke is simply an interruption in the blood supply to the brain. You heard of a heart attack? When we talked about heart attacks a little while, what is a heart attack? A heart attack is an interruption in the blood supply to the heart. Well, the brain is fed by arteries and blood vessels just like the heart, and risk factors for stroke are very, very similar to those of a heart attack. High-fat diet, inactivity, smoking, number one preventable risk factor, poor cholesterol profile, family history, obesity, and For stroke itself, a history of previous heart disease is also a harbinger for a stroke. Most strokes usually occur about 5 to 10 years after a heart attack. Not all, but most. Now, we said it's an interruption of the blood supply to the brain, and there's two ways that this can happen. You can have what's called an ischemic stroke, which you see on the left. An ischemic stroke occurs when the blood vessel becomes narrowed or clogged with plaque. We call that process atherosclerosis. And same thing with a heart attack. If a blood clot breaks off, travels to the brain, or travels through that blood vessel, where that blood vessel becomes smaller and completely blocks off that blood vessel, any part of that brain that's being fed by that particular blood vessel is going to be compromised. Now, this is an important concept to know, because about 25 years ago, once an ischemic stroke occurred, the minute it occurred, the damage was done. Nothing that could have been done. These days, that's different. There are medical interventions these days, such as clot retrievers and clot-busting medications, that can be employed if they are employed in a reasonable amount of time, generally about 3 to 4.5 hours. So what's got to happen in the meantime? You got to recognize the person may be having a stroke. You got to call for help. You got to get them to the proper hospital. We'll talk about that in a few moments. But stroke awareness is very important these days, because whereas 25 years ago you would wish them the best of luck in rehab, the person shows issues of a stroke right now, these days it can be reversed, leaving that person with little, if no, permanent damage. An ischemic stroke occurs about 80 to 85% of the time. It's the most common type of stroke. The other type of stroke is something called a hemorrhagic stroke. A hemorrhagic stroke usually occurs when a blood vessel in the brain ruptures and bleeds into the brain. And the prognosis of that is still not very good, unfortunately. Depends on how bad the bleed is, what part of the brain is affected, but luckily it's more the exception than it is the rule. So now, a stroke, like anything affecting the brain, can have many, many different presentations. And of course, it's kind of impossible at the first aid level, even at the basic EMT, and even at the paramedic level, to memorize all the different presentations of a stroke. But first thing you should do is recognize who's at risk for a stroke. And we talked about that. Advancing age, uncontrolled high blood pressure, obesity, things of those sorts, cigarette smoking. Then if that person doesn't seem right, doesn't seem like they're behaving normally, and you don't think they ingested any drugs or alcohol, they don't have any history of diabetes, there's 3 things you want to look for. So there's 3 things you want to look for when you suspect a stroke. And we typically call this the Cincinnati Pre-Hospital Stroke Scale. 3 parameters: facial droop, arm drift, and speech. So the first sign to look for is facial droop. Ask the person to bite down, smile, show all their teeth. If one side of the face goes up, but the other face just stays in place or drops a little bit, that's one very, very suspicious sign that they may be suffering from an ischemic stroke. The second sign is something called arm drift. Medically, we call it pronated drift. You want to have the individual close their eyes, hold their hands palm up, straight in front of them for at least 10 seconds. If one of the arms drops or they can't bring it up to begin with, that's another very suspicious sign for an ischemic stroke. The next thing, which you can't see on the slide obviously, is have them repeat a sentence with many different vowels and consonants, such as the house that Ruth built, or the skies over Cincinnati are blue, whatever the case may be. If they sound like their speech is slurred, or if they are mixing words, or they're forgetting words altogether, or if they just can't speak to begin with, speech abnormality is a third prominent sign of ischemic stroke. Now, any one of those signs means there's about a 72% chance that they are indeed having an ischemic stroke. So what do? Well, first of all, call 911 immediately. Do not waste time trying to get in touch with the individual's family physician. Do not drive this person to the hospital personally. Do not call an Uber for them. Call 911. First of all, just in case this person's condition gets any worse, you don't want this person having complications such as seizures or becoming unconscious or going into cardiac arrest while they're in your car. Second of all, as I mentioned many times before, not every hospital is appropriate for every condition. You want this person to go to a designated certified stroke center, a center that has the neurologist, the radiologist, the neurosurgeons, and stroke team specialists, and is certified by the state in stroke management to get the best care and the best chances of recovery. Although pretty much every hospital in the New York City area is stroke certified, you still want to make the point of calling 911 instead of private transportation. Another very important thing to do is once you notice that this person is not looking like themselves or not behaving normal, make a note of what time, exactly what time you notice this. That's important. Because as I told you before, as if they're to be considered for this definitive stroke intervention, there's a certain time frame in which has to be employed. Anywhere from 3 to 4.5 hours, depending on the center. And within that time, they've got to be evaluated by EMS, they've got to be transported to the hospital, they've got to be triaged, they've got to be initially seen in the emergency room, they've got to have some blood work drawn to make sure they don't have any bleeding problems. Then they need to get up to the radiology suite and have a CAT scan done to make sure there's no bleeding in the brain. Then they have to come back down. They have to be evaluated by a neurologist, a neurosurgeon. Either the patient or the next of kin has to be advised of all the pros and cons of different treatments. And every minute that goes by risks more and more brain cells dying off. So the clock begins with the definitive note of when these symptoms began. If we cannot recall what time these symptoms began, or if we cannot give a definitive answer to that, that decreases this person's chances of being eligible to receive this clot-busting therapy. So that's a very, very important thing to take note of. And of course, just like anything else, monitor their breathing, airway, breathing, circulation. Definitely try to keep their head elevated. Do not give the victim anything to eat or drink. One of the problems is the stroke itself may affect their ability to chew and swallow food, leaving them to choke or aspirate fluids. Now, here's a question to ponder. If it's a heart attack patient, and we know that blood clots cause heart attacks, we're told to give aspirin to help prevent that blood clot from further developing. Would it be a good idea to give a patient you believe is having a stroke an aspirin as well? We talked about the mechanism. And the answer is no, absolutely not. At least not at the first aid or the pre-hospital level. For one thing, as we just said a minute ago, the person may have difficulty manipulating food in their mouth, chewing and swallowing, which could always lead to a choking hazard. Second problem is even if they present with textbook signs and symptoms of ischemic stroke, we never know beyond a shadow of a doubt until we get a CAT scan if it's ischemic or if they're actually bleeding, having a hemorrhagic stroke. So theoretically, yes, aspirin would probably be beneficial for an ischemic stroke, but God forbid that there is actually a hemorrhagic or bleeding in the brain and aspirin is given, could potentially kill them. So we just keep away from that by all means. The last thing we want to talk about is seizures. Seizure is basically an interruption or a malfunction in the electrical activity of the brain, either for a very short period or could be even a prolonged period of time. Hopefully you guys all did your homework and watched the original 1973 Texas Chainsaw Massacre, because the seizure can happen from a lot of different causes. Seizures. Now, when we talk about seizures, we commonly think of the more common, the convulsive, shaking, horrifying looking seizures. And those type of seizures are called tonic, clonic, or grand mal seizures, and they can occur in stages. First is what we call an aura. People who tend to have a history of seizures, they often know when they're about to occur. They get a feeling of dizziness, they notice certain type of smells, see lights. It's different for everybody. Just some type of sensory abnormalities give them a warning that they're about to have a seizure. Next comes what's called the tonic phase. The tonic phase occurs when all the muscles start stiffening up and becoming rigid. The individual themselves usually loses consciousness or awareness of what's going on around them. And then it's followed by the clonic phase, which is the actual shaking and convulsing of all the muscles, which can last seconds to minutes. And then finally, there's this period of unresponsiveness or disorientation after the seizure, which is called the postictal phase. And that can last minutes to even hours. So when we talk about seizures, a seizure is a sign of epilepsy, but epilepsy is just a catch-all term for anything can cause an abnormal electrical discharge in the brain, resulting in what we just talked about. And many different things can lead to seizures. Lack of oxygen, which we call hypoxia, heat stroke, poisoning, electrical shock, we've talked about that. Hypoglycemia, once they start going into seizures, they're on their way to death. Brain injury, closed head trauma, tumor or stroke. Alcohol withdrawal can actually cause seizures as well. And we're going to have to talk about that next time. Drugs and alcohol and the complications faced with those type of issues. A prolonged ongoing seizure, usually leading after about 5 minutes or so, or 2 or more seizures that occur without the patient regaining consciousness, is a medical term called status epilepticus, and that's very severe. That's a seizure that definitely requires 911 intervention. Some of you may have family members, relatives that have seizure disorder, and may from time to time wind up having a very small, brief 30, 60-second seizure. And this is common. You may not necessarily need to go to the hospital if this is following a specific pattern. But for any seizure lasting a prolonged amount of time, and again, 5 minutes is about the cutoff term, that person, something else and something serious is going on, and this person needs to be hospitalized, call 911. So what are some of the things you do? What are some of the things you don't do in case of a seizure? Well, for one thing, do not restrain or hold the person down. When somebody's having a full-blown tonic-clonic convulsive seizure, their muscles can contract extremely violently. You could get hit in the face, or if you're really strong in holding them down, you can wind up injuring the victim, even causing them to disjoint themselves. So do not hold them down, let it play out. Clear the area of anything sharp or anything that they can actually bang their head on. Loosen ties, scarves, or anything around the neck that can become a potential airway compromise. One of the things you might be able to do is place something flat and soft under the head, like a pillow or a blanket, to keep them from banging their head on the floor. If you can, turn them or her onto their side to allow saliva and other secretions to drain from the mouth. Do not ever try to force the mouth open. Do not stick a spoon or a stick or anything to try to open the mouth, and as they always say, keep the victim from swallowing their tongue. A seizure victim will not swallow the tongue. You cannot swallow your tongue. It's anatomically impossible. Is it possible this individual can bite their tongue while they're having a seizure? Absolutely. That could be fixed in the emergency room. By sticking spoons in their mouth and breaking teeth and causing them to choke, that may not be repairable. Keep an eye on them. Ask if there's anyone who should be called to help him or her get home. But again, if this is somebody that's not known or doesn't have or has a prolonged seizure, call 911, get him to the hospital. All right. So that's basically it. Let's go over a couple of review questions just for study points, just so you'll be in good shape for the next exam coming up. So, blank occurs when coronary arteries that supply the heart with blood slowly become thicker and harder from a buildup of plaque. And that answer is called atherosclerosis. Atherosclerosis is the buildup of fatty deposits, a plaque on the artery wall that can rupture and lead to myocardial infarction. What occurs when either the heart stops beating or the heart's lower chambers suddenly develop a rapid, irregular rhythm, causing the ventricles to quiver rather than contract? And that, as we know, is called cardiac arrest. Know the difference between cardiac arrest and heart attack. They are two completely different terms. Typical symptoms of a heart attack include all the following except, and the answer would be headache. Headache is generally not associated with heart attack in and of itself. Person's having a severe headache, the worst headache of their life, you may actually be thinking of a stroke more than a heart attack. A what, also called a brain attack, occurs when there is a sudden interruption of the blood flow to the brain. The answer to that would be a stroke. And what are the two main types of stroke? There are ischemic, due to a blood clot, preventing blood flow to a certain portion of the brain, and that occurs about 80 to 85% of the time. And the other one is hemorrhagic, due to a blood vessel bursting and causing bleeding throughout the brain, about 15% of the time. Very poor prognosis. Signs and symptoms of a stroke usually include all the following except, and usually profuse sweating is not a common sign of a stroke. Usually common with a myocardial infarction or a heart attack. Headache, one-sided paralysis, and difficulty speaking are all pretty much consistent with ischemic strokes. What is a chronic lung condition that may occur in episodes of cough, wheezing, and tightness in chest? That is asthma. Asthma, as we said, is a chronic lung condition that has episodes of acuteness and usually is something called an acute on chronic situation. Episode is asthma. What is the most common cause of COPD, whether it be emphysema or chronic bronchitis? Answer, as I kind of stressed before, is smoking. Smoking. Sudden onset, pale, school, kin, rapid change of mental status is consistent with hyper or hypoglycemia. Let's think about that. Very sudden with cool, pale, rapid change of mental status would be hypoglycemia, very low blood sugar. Which of the following is a proper intervention for a victim experiencing a convulsive seizure? Hold the victim in place, insert a spoon in the mouth, pour sugar into the mouth in case of hypoglycemia, or leave the victim alone and move any potential objects that he or she may strike their head on. The answer would be D. Just leave them alone. Don't put anything in their mouth. Don't force them down. Call 911. All right, ladies and gentlemen, that is it for this week's lesson. Once again, I encourage you to post any questions that you have on the discussion board, and please go over any instructional videos that we have in this week's lesson. Have a good week.